Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio, and delighted to be back with you on this, yet again, cloudy morning. But the sun will come out soon enough, and actually we've had a little sunshine here at KU because our numbers are at levels we haven't seen in a very long time. Before I go to Dr. Hawkinson, though, let me first of all introduce a couple of great folks. I've known Dr. Teresa Long since we were both very, very young, and since I failed to make a Star Trek reference yesterday, I'm going to make a really cool one today, because if you remember The Next Generation, the name of the counselor, Deanna Troi, who helped guide the Captain Picard through all of his troubles, that is who Terry Long has been to me so long here at the health system as one of our outstanding psychiatrists. She is a pain specialist, and she is here with Dr. Roopa Sethi, who is our addiction clinic medical director. But before we turn to them and have an ongoing discussion about mental health and the pandemic, which is incredibly important, even as we emerge from the pandemic, we're going to get into that.
Yeah.
The ray of sunshine.
Yeah, ray of sunshine. So let's just say that Hays has 3 patients, 1 active and 2 in that recovery period. But here at the health system, and maybe we can attribute this to Amanda Cackler, our great director of infection prevention.
Maybe we should give her that credit.
Right now here at the hospital, we have 8 total patients, but 3 of them are active, but all are asymptomatic.
Meaning they came here for a reason other than
right.
COVID.
Yeah.
Huck, I could cry. I mean, we've not been at this level. That's like we have 0 truly COVID patients
it's probably
in the
like
hospital right now.
March or April of last year.
That's crazy.
So I think we, that is a great way to continue our early week here right now.
It is. But you and I were on our chief medical officer call yesterday, and the news wasn't as good across the city because we had a number of hospitals that still had a pretty active census.
Yeah, there were, usually we had been our hospital had more patients than a lot of places, and that was definitely not the case yesterday, even when we had those active symptomatic patients. But yesterday, talking with the other CMOs around the region, it sounds like some of those hospitals definitely have more than us.
Yeah, I mean, Liberty was up I believe, around 11. Some people were at 20 or 16. So we are uncommonly low, as it turns out, in the community, which we're happy about. We just hope everybody gets down to that low of a level.
Yeah.
Although most folks had the same story we had.
Yep.
They had a pretty asymptomatic population, meaning that they were catching these on admission screening or procedure screening, et cetera. Another piece of good news, Moderna this morning reporting that their shot looks 100% effective in over 3,800 adolescents aged 12 to 17 at preventing hospitalization or death. Yeah. That is another remarkable finding and another victory for the mRNA vaccines.
Yeah, 2 words, vaccines work. And we have seen it in the patients that are coming in that are asymptomatic. Again, we have patients admitted here, but they're not here for that reason. And it also goes to who we aren't seeing, and that is that older nursing home, high vulnerability patients. And so I think that's important to note. Continue to encourage vaccination and everybody get it because we know they're safe and they're extremely effective.
So vaccines work, and the 3-word phrase, vaccines are safe.
Yeah.
Yeah, and who knew? Vax work. Let's see if there are questions out there.
Sure. Good morning. Cody Holyoke, Channel 9.
Hey, Cody.
Congrats on the low numbers. I'm curious, when was the last time you haven't had any COVID patient in the ICU?
Cody, I think we'd have to go back to March or April. We're going to have to. I was a little surprised by the information this morning. We'll have to go back and find out. We'll answer that question tomorrow. But it has been. I bet it's been over a year.
Yeah.
Wow. Yeah. Real quick, talking about the vaccination numbers, and we get these from state health officials every other day. Nearly 35% of Kansans, 34% of Missourians are considered fully vaccinated. I know for a long time, you and other health experts have said we have to get closer to, was it 70% potentially to really get on the other side of this thing? But we're starting to see many openings, as you said, the K going to full capacity next week, other sports and entertainment venues opening up. There's a disconnect there. So what are your thoughts on that?
Yeah, it is a disconnect. I agree, and I wish we had more people vaccinated already. You know, we've got a lot of vaccine. and it's not going used. The state does too. We have some vaccine that'll expire without getting used. I mean, that's not where we would like to be. I know there's still too much vaccine hesitancy. I know there's still a lot of vaccine denial, and I fear for that. But I think what we're seeing, and the reason our numbers are this low, is that there are a lot of people who have had COVID. And there are a lot of people who previously have been wearing masks and doing things who are getting vaccinated. And I think what has happened is that means about 70% of the population has either been vaccinated or has had COVID. I'm guessing on the total number of had COVID. I don't think we really know it. You see estimates from 15% to 45 or 50%. So I don't really know, but here's what it feels like as a health system. You know, we are the downstream recipient of those people who are unvaccinated, right? Unvaccinated and ill and have to be hospitalized. And we're not seeing as many. Now, in fairness, that's not the full story across the metro, so let's be a little hesitant because, again, yesterday's conversation with our chief medical officer revealed that even though everybody's numbers are mostly down, a few had an uptick in the last few days, the last week or so, in their census. And we had a number of hospitals yesterday who said, you know, we were lower last week. We've seen a little bit of an increase now. And I think we just have to be cautious about what that means as far as how we go back out into public. But if you just looked at our snapshot of it, you would say, okay, 35 or 40% of people, or 35% of people have been fully vaccinated. You look at the U.S. data, and about 49% of people have had at least one dose. Yeah. And if you couple that with it anywhere from 20 to 30% or 40% of people who have had COVID-19 and who have not been vaccinated, you've got a pretty significant number that are probably more resistant to severe disease. And I think that that's probably why our numbers are lower. But again, they're not as low as they could be, because if we had people getting their vaccine, we would really drive this number down. And that's what will make us very safe. The other thing you have to remember is that the variants, your host immunity when you've had COVID-19 is really to a very specific COVID-19 configuration, the wild type, if you will, from that was the original one. And you may not succeed as well against the variant, so you're still susceptible. We saw that's what happened in England a few months ago.
Yeah. Yeah, no, and if you remember, you know, traditionally when we think about herd immunity or population immunity, we are really looking for that 80 to 85% or more of people that have been are immune either through vaccination or immunity. So that's very important. And when all of this came up with population immunity due to vaccination here with COVID, a lot of that conversation did not include that whole sub-segment of the population, those 16 and under, which are a very significant part and also can spread the disease. So we are trying to look for more and more people. And if you think about it as if we can get 80 to 85% of the population, that overall cuts down on the number of people that are susceptible and can spread the disease. So we are getting there. You mentioned the numbers about the total population that has received at least one dose. And I believe in that total of 49% of the population, I think it's 65% of total adults. So we are getting there, and it's a stepwise method that we're going on with this. But hopefully we will get there, and with, you know, children now being able to be vaccinated, that's going to be one step closer to that whole protection. Because there are data signals that the vaccine immunity, especially if you only had mild or moderate disease, and especially, say, back before the turn of the year, before the UK variant was the predominant variant that was circulating, your immunity probably isn't as good with that natural infection as it could be if you get vaccinated. So it's going to be still important to continue to endorse vaccination for everybody, even if they had COVID-19.
Other questions?
Quick, follow-up to that. You mentioned numbers starting to pick up in some of the hospitals around the area. Does that jive with a timeline for reopenings? Because really in the last few weeks, we've seen a lot more reopening. When do you start to look for a trend from infection from reopening?
Yeah, I'd say sometime over the next week or two. We know that what happens when you go out, a few people start getting more infected, and then that's like that little, you throw a stone in the water and you watch the ripple effect. And I think what we'll have to see is sometime in the middle of June, we'll really have a better sense of what reopening is meant. Yeah. I think before then, we're watching the trends very carefully. If you were looking at our health system, you would say, gosh, things are okay. If you looked at a couple of other hospitals around our area, you'd say, oh, I'm a little nervous. And so what we've done traditionally is when we look at it, we try to gather all that data, and you'd say, okay, if we put them all together, we're probably treading water. But there are signs in there that we have to be very careful with. But again, these still numbers overall are still much lower than they were at their peak. It's just something we have to be careful of. But we really won't know, since testing isn't the same as it was in the fall when people were more apt to get tested with a cold or flu symptom. I think what we now have to say is it's hospitalizations that are the bellwether. And actually, I think they've always been the bellwether, because that's the one way you took the question of community spread, or how people were getting tested, or the number of tests people had, whether the tests were accurate. You took all that away. You just looked at the number of sick folks in hospitals. Today, like I say, we have 3 patients who are hospitalized that have COVID positive tests, but none of them are here because of COVID. And that's a remarkable statement. And the second part of that statement is that some of our other hospitals in the area have seen a recent uptick in the number of COVID positive patients who are there because of COVID. I think that's for real. We just have to bear watching. But I think, Hawkeye, I'm going to say middle of June before we really know what the impact of opening is. And when we start thinking about large outdoor events like going back to Kaufman, I think that's probably the 1st of July. Although I'm pretty confident in Kaufman because I think it's outside. Well, I know it's outside. I don't think it's outside.
No, I agree with you with the outdoors. And my point only was what you brought up. I think moving forward, we do all anticipate that hospitalizations is going to be the bellwether on the significant impact of COVID in the community, just because people, for one reason or another, maybe aren't getting tested. So I think moving forward, within the next 4 to 6 weeks, we'll have a lot better gauge on really how things are going.
Dr. Long, did you want to weigh in on that?
I'm just enjoying the conversation.
Okay.
I've noticed some of my patients with the doubtfulness about the vaccine, and I've spent a lot of time educating over the course of the last year. A lot of patients say, well, I'm too sick to get the vaccine, and we have to turn that over. And others listen to media reports of people having side effects, and we have to describe the difference and spend time educating the difference between a couple of days of feeling a little punk and becoming seriously ill with something that can have very long-term effects. And so,
Yep, I would totally agree. All right, other questions? Not hearing any. Okay, Dr. Troy, I mean Dr. Long. So how has this pandemic impacted the patients you serve? You made mention of that just a few moments ago. Are demands for your services higher than ever, and for our psychiatry team in general?
I think so. We've had a lot of patients, those with underlying anxiety disorders. These have escalated. People are having a lot more difficulty coping. If you think about it, when you have certain coping strategies, to go take a walk, to go visit a friend, to spend time with someone that makes you comfortable, and then that's taken away, people with anxiety disorders have a lot more difficulty. And we know that isolation and lack of activity and lack of personal contact really worsens depressive symptoms for a lot of people. So I think that is true, that we really have had higher need for our services. Just general distress. We see just general distress, even with people who don't have underlying psychiatric illness. This last year has been so tumultuous, and there's just been something to get you on edge most of the time. And our patients, my pain patients, even those who don't have depression or anxiety, they feel it too. They feel it too, and may have, with increased anxiety, increased pain. And certainly when you can't distract yourself from your troubles as easily, things just get worse. So,
I would think that as we emerge from the pandemic, there are people who have just been, and it feels this way in the medical staff and with our hospital staff, people have just gritted their teeth and said, I'm going to get through it. And when they come through it, it's been a little damaging, right? It's just been hard. And when you start to go back out and you think it's going to be normal, you're not normal. I just feel like somehow folks have faltered a little bit in trying to feel normal again. Is that something you felt?
Well, it's hard. It's hard, isn't it? We've had certain things beat beat into us
over
the course of the last year.
Wear a mask, take so. I know.
That's right.
True. Guilty.
I'm
Guilty.
sure we've all had the experience. You watch the TV show that was filmed before the pandemic, and in your heart you're thinking, oh my gosh, they're not wearing their masks. And it just looks odd, doesn't it? It looks strange. And so I have patients who are still quite apprehensive about coming back out, even after vaccination. And I understand that. And I explain to them they can take their time with that. If they feel like they need to mask and still avoid things for a while, I think that's fine. Go ahead and take your time. Do what makes you feel safe. But it is time to get out in the world, get out in the air, and try and bring back some of that interaction that is so good for our souls.
So, how have your patients who have had COVID done? Has that got its own set of psychiatric issues that we've really not touched on too much? We talk a lot about the impacts of COVID to us as a world, but what about the psychiatric impact of COVID on the people who've had COVID?
There's a number of syndromes that people have seen, and there's some early research out there looking at this. Patients, some have some cognitive clouding, just slow thinking, fuzzy-headedness that they experience for a period of time, and then worsening of anxiety and depression. We know that individuals who are hospitalized with COVID are very frequently will have what we call delirium and confusion in their hospitalization. So this makes everything harder.
So if I'm not remembering or hearing things that my wife has tried to tell me, can I blame COVID fog for that?
I'd
Is
go
that
for
possible?
that. Yeah, I'd go for that one.
I'm afraid I may not have had COVID, but I'm
Well,
going to blame the fog.
yeah.
I think it's kind of like those vaccine things that can jump from one person to another and they can make you feel sick anyway. That's not true, people, by the way, but COVID fog.
But it's interesting. It's interesting that you say that, because I think the other side of that coin is that many people will attribute things to perhaps COVID that may not be. And the fuzzy-headedness. Well, I can't think clearly. We know patients with depression, anxiety, and other psychiatric illnesses can be very distractible. And when you have so many worries on your mind, it's hard to focus. It's hard to concentrate. And so a lot of times, that's what the issue is. It's your own internal distress and distractibility, and not something caused. But it's worth following up on. So maybe I'll check that out.
Yeah, maybe I should get those antibodies checked. That's what I'm talking about. So, okay, for both you and Dr. Sethi, if somebody is on pain medication, how do they know if they're an addict? Let's say they run out of pain medication, they have withdrawal symptoms. Does that mean they're addicted to pain medication?
Well, not necessarily. Roopa, do you want to handle that one?
Sure. So when a patient comes to us, we want to differentiate between opioid dependence versus opioid use disorder. Sorry, those are two fancy terms, but somebody, say you have a patient, you started a pain medication, and after a while, they'll need higher and higher dose to get the same effect. That's called tolerance. And if they stop taking the medication, they will have withdrawal effect. And those are like normal physiology of being on the opiates. That is not addiction. If the patient, however, has other things like getting it from the street or running out early or having social interpersonal problems or cravings. So for example, you're watching TV, but you're thinking of all is that I need to take my med, I need to find my med. Those kind of symptoms, they point more towards opioid use disorder. Having said that, if you're opioid dependent, it can be tackled a different way than opioid use disorder. So for example, the opioid use disorder patients will actually end up coming to our addiction treatment center and seek treatment there. Whereas opioid dependent patients will still follow Dr. Long, and Dr. Long can probably speak about that.
Right. It's so much a different thing. I will tell you, I had one patient that I think described it very clearly. She said, I know I have pain, and that is going to be there. I'm going to have to deal with that. But I know that when I took that medication, I was chasing the pill. I was looking for the pill. I was trying to get that next. And so it's qualitatively, it's just a little bit different there, isn't it? Whether you're taking the medication purely for the pain or if it's just to take the medication. And it's very hard often for patients to determine the difference. But that's what we can do. We can help them understand
And in fact,
that.
hasn't it been hard for healthcare practitioners to determine the difference? I mean, for a while, I remember we went through the phase here in the hospital where no one should have any pain, and we were just giving pain medicine.
Yeah.
And then all of a sudden, we ended up with a large problem with opioid dependency in the United States. Help us wrestle with that. I mean, how much of opioid dependency did we as healthcare actually feed into or even create?
I think that's very fair, and some. I will say that there's no doubt. But there's two sides on that. We do know that when you're exposed to opiates and you're at risk for developing an opiate use disorder, that risk really, really goes up. And there is a window of time in there when some of that can start to kick in. So the use of the opiates in themselves, for some patients, even for a couple of weeks, is enough to trigger that craving. And so it can be problematic, and we need to keep an eye on that. We did for a long time really truly believe we just needed to give people what they needed, and that some of those signs that Dr. Sethi mentioned were really the only thing we needed to look at. But it's a little more nuanced. It's a little more detailed than that. So we need to help our patients understand that, yes, they've had an operation and they will need pain medication, but it isn't probably wise for us to give an unending prescription for that pain medication. Normal healing takes a specific amount of time, and we need to follow closely if their pain lasts beyond that period of time. Well, it's not just a matter of needing more pain medicine. Maybe we need to look further. But I think we did cause. I do think we did. We opened the door. We opened the door for the opiate use disorders and for people who are vulnerable. Now, I will say the other side of that coin is one that I think is not as clearly understood, and that is what happened when the guidance changed. What happened when the guidance changed? And the CDC guidelines came out, and then afterwards the Health and Human Services guidelines, which I think are very helpful. But many doctors felt like these guidelines were telling them they were no longer supposed to prescribe. And so patients that they'd been prescribing for a good long period of time, they suddenly said, well, I'm done. This is all I'm going to do. And patients then didn't know what. They experienced the withdrawal effects that Dr. Sethi has described, and they weren't sure what they were supposed to do. And that there is a population of patients who did look for illicit substances, began doctor shopping in order to solve that problem that they had. And so I think that on both ends of this, we've added to the issue. Roopa, did you want to speak to that?
I was going to say, Dr. Roopa, or Dr. Sethi, this is kind of your area as well, because we do have an opioid crisis in America. How do we move back to a place where we say to patients, yeah, you're going to have some pain, expect that? How do we balance that with pain medications? Because pain medications it's hard to make you pain-free without being, I think, just maybe a little over-sedated.
Right. So, when a department contacts us, so for example, somebody has a pain patient who is on a pain medication, and they'll sometimes contact us, and we always ask them to get a consult from us, and we can always help at least determine whether the patient is meeting criteria for developing some kind of addiction. And if not, they can at least treat them as their own patients. If, however, they developed an opioid use disorder, for example, at least we can take them over in the addiction clinic. Our medications are opiates. Two of our medications, one is Suboxone and the other one is methadone, and they work on the same receptor as the opiate. So in a controlled setting, they will help somewhat with the pain. That really helps the patient. However, the big thing that we always tell the patients is that the pain is not going to go away totally. And a lot of therapy at that point helps. We do cognitive behavioral therapy that works very well. In the clinic, I do motivational interviewing with the patients, and it helps them move forward. And I think those kind of modalities are okay, because when we were a child, if we fell, we would feel pain. So sometimes just educating the patient that it's okay to feel pain, but how much pain can you tolerate, it depends on that. Having said that, if our patients in the addiction treatment center are undergoing surgery, we actually have a release signed with who the doctor is, and we communicate with the doctor and say, you have two options. One is for a little period of time, if the patient needs opiates, you can go ahead and prescribe opiates, and then we will take over again. However, our medications are also working on the same receptors, so we could actually change the dose of those medications and the frequency for a small period of time, and then we can bring them back into our clinic and bring them back on their same doses. And it has worked very well with our doctors inside KU as well, because we have worked very closely with them on that.
Okay, so let me just ask you both this again, just for our listening and viewing audience. How does somebody know if they're addicted or dependent on it? What are those risk factors that you mentioned?
Oh my goodness. The things that really strike our eyes are, like my patient said, the focus is more on what the medication is, what the pill is, rather than the effect and whether it's allowing me to be more functional. The idea that I prescribe pain medications so people can get up and do, so they can be more active. And if I find that there's a decrease in their function, their family says they're just not doing anything, they take the pill and they nod off, this is a huge sign that there's a problem with that. That's not the effect that I'm, I want people to be able to get back to work, take care of their families, and take care of their homes. And so those sorts of symptoms. The craving, the thought that I'm chasing that pill, I need to go. Doctor shopping is something people often talk about, going from doctor to doctor to find this medication. That's a very important sign. But if you look closely, there are some patients who their primary physician has just quit prescribing, and this is the only thing they know how to do. So even that we need to look closer at. We need to look at patients who will take more doses than they need to control their pain. They will continue to take higher and higher doses and feel like that isn't sufficient. Dr. Sethi, do you want to add more to that?
I actually would like to add two case scenarios, for example. So say, and I'm making up these case scenarios, but 76-year-old female comes to my clinic and has been on some kind of opiate for last 25 years or 30 years because she was prescribed. She takes it as she was prescribed. She has never bought it from the street. She's never run out of it. However, she was referred to our clinic because it seems like she might have developed opioid dependence, which she has, where if she takes lesser than that dose, she's 76 now, she gets very severe withdrawal symptoms and is very uncomfortable. And she is feeling that she may be needing more because this dose is not working. Now, this is a normal physiology of being prescribed an opiate. This is not an opioid use disorder. Now, I'll give you another scenario. So another 76-year-old, I've had more of 70s in our clinic as well, so I'm giving a 76-year-old again, comes to our clinic and has been on opiates for a lot of years. But now has been running out early, so has been going to another urgent care or ER to get another fill for a few days till the next prescription is there. The wife comes in and wife says, well, my husband is there physically, but not there mentally. And then, he's spending more and more time thinking about when to pick up the medication, take his medications, or be ready for his medication. And then he's like Dr. Long said, nodding off after he takes his medications. Or, if he's missing out on his family time, he's not going to church anymore, or he is not socializing with the family. And recently, for example, he was very sleepy and sedated, but he drove to work. And I was very scared because I got a phone call because he got into a little bit of trouble. I mean, those kind of things. And you don't need to meet all of these. You actually need to meet just two criteria of these. But these kind of criteria are pointing more towards it has become a use disorder. Sometimes it is very difficult for physicians to even, determine whether it's just dependence or use disorder. And that's when Dr. Long's expertise or, referral to our addiction treatment, I should say a consult to addiction treatment center is helpful to determine whether this is just physiological dependence versus is meeting criteria for use disorder.
Yeah, and that 76-year-old still going to work, man. I tell you what, I call that Tom Brady or something. Hey, would we be surprised to learn who is dependent and/or addicted to their medication? I mean, can that happen to anyone, guys? Dr. Sethi?
Sorry, I missed your question.
Would we be surprised to learn who is dependent or addicted to their medication? Meaning, I guess this can happen to anyone. You don't have to be 76 or 74 years old.
Absolutely. Absolutely right. Can happen to anybody. And it's just the nature of opiates. They make you dependent on them. And then once you're dependent, it's a very, very thin line where you can just cross to the other side and develop an opioid use disorder. So it's very important because of the nature of these medications, the kind of medications they are, that people be more vigilant when they're prescribed these medications.
Yeah, I think that makes sense. How can people get help, guys? How do you get help here?
Well, I think first is to recognize that something is not going as it's supposed to go. That either you're starting to have some arguments with your doctor about whether or not you should take the medicine, or your family about whether or not you should take the medicine. It's very easy to call our addictions clinic to get that evaluation, to find out where you stand on that, and what is the likely best choice for you for your treatment. If you have your primary care doctor is a good source to be very honest with them and say, I think I'm having an issue here, and they will be able to help link you in with addictions clinics. And we have a wonderful group here that takes care of a lot of people, but there are other people in the state and around the community that are available as well. So it doesn't matter if you're a Kansan or if you live in Missouri, there are resources. And you can be referred, you can ask our clinic here, you can ask your doctor, and they can get you lined up with those resources. Sometimes a clinic social worker has the best connection for you.
All right, really good advice. Go ahead, Dr. Seth, you had something there.
I just wanted to mention with the new change of the Suboxone X waiver that recently happened. Earlier, all the physicians needed to get 8-hour training in order to be able to prescribe Suboxone for opioid use disorder. However, now, if you have a DEA license, which all physicians do, then they can just go ahead and prescribe, but make sure that the number of patients that they hold is less than 30. And they can actually treat up to 30 patients with Suboxone for opioid use disorder. So for instance, if you have a patient that you've been treating for years on an opiate and you think is having very hard time coming off of it, or you think has started meeting some criteria for opioid use disorder, would be a good transition to Suboxone right in the clinic, where they don't have to really come to an addiction clinic at that point. However, if it becomes unmanageable, then we are always there, and we'll always take the patient and help everybody.
Yeah, I'm sitting here thinking I got a couple of patients I need to send to y'all, especially with these changes in Suboxone, because it does sound like it's made such an advance for helping those, either with dependence or addiction. Is that fair? Yes?
Yes.
Okay.
Yeah.
All right. Well, Jill, let's see what questions are out there in the community. You look like you have a smile on your face, which means there are a lot of questions, Jill.
There are, and we don't have a whole lot of time left. So the first thing we want to clarify is, could you go over the numbers? There's confusion over how many active, how many recovering, how many in the ICU, and how many on vents. You guys got really excited, and they're just not sure they're understanding.
That's probably.
And I did receive a subsequent text from the numbers. So part of the problem was our easy dashboard to look at was down today. But overall, the numbers are going to be 3 confirmed cases, but none of those are symptomatic.
So they're still active, but they're just
actually, so
distinguishing.
here's the deal. Let's be clear. What happens is, if you're admitted, we do a pre-admission testing on everybody who comes in the hospital. If you're positive, we call you COVID positive. That doesn't mean you have an active infection, meaning you're here because of COVID. You're here and you have a COVID positive test.
Correct.
So that's 3.
Yep, and that's admission PCR screening. So we do that for just continued infection prevention purposes? Do you need gown and gloves when you go into the room? Things of that nature. And also to be aware that, we also are continuing to test people just in case they need procedures, because we know that procedures, people can have higher risk of complications if they are COVID positive. So those are people that we found on admission screening who came here for another reason. Those are the only positives we have. We do actually have another 13 that are in that recovery period. So a total of 16. None in the ICU, none meeting ICU criteria. Again, our 3 active patients are here for other reasons. They are currently asymptomatic, meaning no symptoms.
Which is different even in some of our, as we said before, some of our other hospitals. And the fact that we don't have anybody in the ICU that is here because of COVID is a remarkable statement. And we just haven't been there for a very long time. And the fact that we have no one who's acutely ill with COVID, not only not in the ICU, but even in the hospital, because these other 3 people are all folks who have positive screens, so they're not really hospitalized because of COVID. Now, some of the people that you mentioned who are recovering, they were hospitalized with COVID. But that means they've been here for more than 10 days.
Yeah.
So,
or 10 days from their symptom onset. Or
you bet.
Yep.
Okay, and then we have some people that are asking, these patients who are hospitalized at KUMed, Jennifer wrote this, for other reasons, but who are also, now she's saying active COVID, but we're learning that they've just tested positive.
Yeah, they tested positive.
They would not be considered active. She wants to know, were they fully vaccinated?
Yeah, but again, the two were, and here's the story. Remember, the vaccine doesn't stop you at all completely from getting COVID. You can still get COVID, you're just not going to get sick. So these other 2 people are here. One is having knee surgery. I forgot. One is having something else done. Oh, it's labor and delivery, and they screened positive. They've both been fully vaccinated. They don't feel sick, but they screen positive for COVID. Well, that can still happen. Remember, the vaccine is 95% effective against severe hospitalization or death. It doesn't mean you can't ever get it. It does decrease your chances of getting it, but it doesn't prevent you entirely from getting it. So I think that's how we have to look at that.
And I would also ask, and I don't know that we know this, are those patients, were they positive a month ago or 2 months ago and are still shedding? It's just that we don't have evidence of that. They were positive on our initial screen, so they're going to be put in that category. But they are not in a cohorted unit and don't actively have any symptoms of COVID.
It's because they could have been shedding because they're asymptomatic, so we don't know. As we have discussed on this program, a number of months ago, you can shed COVID at times for quite a while.
Yes. Yep.
So are they surprised when you say, oh, you're COVID positive? Do you know if they go, oh, wow?
I think some probably are,
Yeah.
I don't.
Yeah, most people don't think they are because they're asymptomatic. They always say, oh, COVID's going to be terrible. COVID is terrible if you don't have vaccination. And once you've been vaccinated, having asymptomatic carriers of it isn't a shock. It should not be a shock to any of us, because that was always the concern, is you could still shed it and make others sick. Now, we know that the chances are also markedly reduced that you will shed it post-vaccination, meaning that you can make someone else ill.
Yeah.
Having people be COVID positive and post-vaccination and being asymptomatic should not be a surprise.
Okay, Isaac wants to know, during the pandemic, how many patients have been admitted to KUMed for drug overdoses, and how does that stat compare to pre-pandemic? Do we know?
Okay, guys. Yeah,
I don't know that number. I don't know
Anecdotally,
that.
is it more?
Anecdotally, I think we do have higher numbers. I would say anecdotally we do. We are seeing more people. There are some drugs on the street now that are opiate connected or combination sorts of things that are newer in this last year or so. I know Dr. Sethi is very familiar with these, and because people are coming to her and saying, look, I've been using this particular thing, the lacing of other drugs with fentanyl type products, or fentanyl family of products, is becoming more common and much more dangerous. And Dr. Sethi?
Sorry? Dr. Sethi, talk to us a little bit. What are people lacing these days? What are they using?
So this drug is called the M pill, and I think if you look at an oxycodone pill, it has a M30 engraved on it. So it's a fake oxycodone pill that is being manufactured, looks exactly like the M30 pill, but to make it more attractive, there has recently been more fentanyl that is in there. Now, if young adolescents or somebody who thinks he's taking an oxycodone ends up taking a pill that's a fake, fentanyl pill. So it is a mixture of oxycodone and fentanyl. And from what I have read and heard from patients is it's not done pharmaceutically. It's just manufactured by a local person. So as a result, the fentanyl is not evenly distributed. And one pill might have more fentanyl than the other, to the point they can have anywhere between sometimes 0.2 to 5 milligrams of fentanyl in it, which could lead to an overdose and death. We have a couple of patients in our addiction clinic that in last year have reported the use of M30 pill as the pandemic hit, because that was the most readily available pill on the market, and they are aware, and we are also educating them about it having fentanyl and it being 50 to 100 times more potent than morphine and can lead to an overdose.
So talk to us a little bit about, what is so dangerous about fentanyl in particular?
Dr. Long, do you want to go for?
Well, as you said, it's much stronger than oxycodone, and people don't understand those connections. And then to add into that, if you don't know how much of it you're taking anyway, you can easily slip over from what you're intending to just get high or whatever to a severe overdose, just because you don't even know what you've got.
Just to think about it like this, folks, usually we talk about fentanyl in micrograms. We talk about oxycodone in milligrams, so fentanyl is 1/1000th, 1 milligram, or 1 microgram is 1/1000th of a milligram of oxycodone. So fentanyl is very, very potent, and you should be very, very, very careful. And when you see these people who are overdosing and don't wake up, don't we think sometimes fentanyl?
Yes.
Gail says her husband's waiting since March to see Dr. Black to help manage his pain. It seems like that this is a long time. He needs a larger dose of pain meds. His PCP has lowered his opioid dose so much he's in pain most of the time. What can they do?
Dr. Black is a pain psychologist, and she has done a marvelous job in helping people figure out how to cope with their pain and how to cope with changes in their life. Unfortunately, she is just one person and can only see so many people, so that makes it more difficult. Yes, most physicians are trying to decrease the opiates for their patients. My mantra in my clinic is best function at lowest dose, and so I will continue to try and decrease the dose, but I will monitor function. I will increase the utilization of procedures, of physical therapy, of psychotherapy with Dr. Black, and other things, that acupuncture, massage, anything that the patient can do, exercise, to help improve their situation, and try and get the focus not on, I need to take this pill, but what are the strategies that I can actually mobilize myself to improve my function.
Massage, that's a word I haven't thought about for a while. Man, I think I need to do that. Okay.
I think it's getting safe.
That sounds really good.
But it's definitely a multimodal way or method of going about to help.
Yeah.
A complex issue for sure.
Right.
And Judy says that her PCP used to prescribe her pain meds a year in advance.
That's a long
And she
time.
said, I never get pain from other doctors. She knows I know how to take and don't abuse it. My concern is not being able to get my scripts. What would you say to Judy?
Well, you're in advance for most people. I think it's a long time.
That is not advisable. Yes, that's not advisable.
Things change.
I see my patients at the very longest every 3 months, and sometimes I'm sometimes seeing them much more frequently than their primary care doctor. I think that for many patients they can manage that, but if you are prescribing that far in advance, as we said, the patients that are using these medications are at higher risk of developing opiate use disorders, and things could spin out of control quickly, and you wouldn't have any idea that that was happening. And so, yes, it's convenient, but I don't think it's the best practice to give that much opiate, and I would not recommend that.
Dr. Sethi, how long do you work on the addiction clinic? How much in the opioid dependence area, how much of a supply do you give patients as you're trying to work with them?
So initially, when they come to our clinic, we actually see them on a weekly basis. Once they are doing better, they get month supply, and just like Dr. Long, my longest patient is about 3 months. And these are like very stable patients who we know. And intermittently, our clinic will still give them a call and say, you need to come in and just do a urine drug screen for us, a random urine drug screen at times. But yes, we monitor them very closely, no more than 3 months at all.
All right. I think time for one more question.
Okay. There's just general questions about being vaccinated, and is it safe to go to X, Y, and Z, and can I still shed if I've been fully vaccinated? You want to just cover that
Yep.
one more time?
Let's
People
do
want
it.
to know about going on cruises and all
All right.
kinds of
Cruises are probably the one place I'm still a little nervous about. Hawkeye, what do you think?
Yeah, I mean, as an infectious disease doctor, I've tried to stay off of cruises.
Well, they said they say
general.
that they're requiring them to be vaccinated before they get on, and they want to know, does that
help
you know? I don't know if the staff is vaccinated, and you still got to get there, right?
Yeah, I mean, if we're talking about purely getting on a cruise and being able to show proof of vaccination, I think you're as safe in that situation as you are in any other situation if you're vaccinated. If you can ensure that everybody else around you is vaccinated, that's even more important. What we've said is we know that there's a large population of adults who are vaccinated, but you have to assume that when you go out in public right now and go into those places, that not everybody is vaccinated. So if you are going to places and going to events and doing things where they do require vaccination, you can feel more comfortable in doing those types of things. Can you shed? I know that question came up. You probably can shed a little bit, but it is significantly reduced so therefore your ability to express enough virus out into the environment to infect other people is significantly reduced compared to if you weren't vaccinated.
Yeah, yes. I think that vaccines clearly keep you safer. They make everybody else around you safer. They don't have significant side effects. It is absolutely the way to go. Live long, prosper, get the vaccine, and make sure that you keep yourself, your family, your loved ones safe with you. It does clearly decrease the incidence of it.
Yep.
It decreases the shedding of it. You can still get COVID-19, but you're not going to get sick with it. And I think that's the key thing. And it's not a protective bubble around you, so that, again, you can still get it. You're just not going to get sick with it, and that's the key. So your chances of getting it are markedly reduced, but the thing that's really reduced is the chance of being hospitalized or dying from it. Hey, we have tomorrow is our 300th episode of the Morning Media Update. We continue our focus on mental health as the month of May winds down. We have a patient who will join us tomorrow with her doctor. Olivia Ashbrook struggled with anxiety during the pandemic. Her psychologist, Dr. Greg Nowalnik, who has been on our program before, joins to share how together they tackled Olivia's worries and her fears. So also coming up on our 300th episode, we're going to have a great time with that discussion, and we'll explore more about what anxiety has meant to people throughout this pandemic. Hey, more and more 12 to 15-year-olds are rolling up their sleeves. Meet another one. This is 15-year-old Dylan Markey, who got his shot at our mass vaccination clinic in Olathe. He's with his mom, Jennifer. He took his first vaccine like a champ, and while Jennifer said at first she had reservations about the vaccine for her son, she changed her mind for a good reason.
I also have reservations about him getting COVID and any long-term effects from that. So I feel that he's much more protected with the vaccine.
It was really important to me to get the COVID-19 shot so I could feel safe. I have a bunch of friends that are hesitant, but also a bunch that are going to get the vaccine. And I'll let my friends know to get the vaccine because it feels good and it's not that bad. Go get the vaccine. Let's end this pandemic together.
Man, I like that. End this pandemic together. How are your kids doing?
Yeah, get the vaccine. The kids are good. Like I said, even the day after, my daughter was asking when she should start to feel symptoms. They just had a little bit of shoulder pain, but that was it. And I should note also that the kids had their annual physicals yesterday, and my daughter had to get 2 other required and routine vaccines. So that's good. So please, everybody, get your children to the pediatrics visits. Get those vaccines for those vaccine-preventable diseases. keep them safe, keep yourself safe. And thank you to our guests. We do know and understand that the opioid pandemic is significant and was only made worse by this COVID pandemic as well. So, we have people and resources here to help. If you know of anybody, please have them seek out any local resources to try to get them help if they are addicted to those opioids.
Yep, so important. All right, so Dr. Sethi, final thoughts from today.
If you have somebody who's struggling with, you think, what is addiction, call us. We can help you. Dr. Long and us, the Addiction Treatment Center, works very closely, and we can be there for you if you need any help.
Thank you, and thank you for being on the program with us today, Dr. Sethi. Dr. Long.
Just bear in mind that, well, I guess I would say not every pain requires an opiate. Sadly, this is probably true, but that there are those that do, and we want to make sure that you can use these medications safely and can help you if things don't work as well as you'd like. So.
Thank you, guys. Dr. Long, thank you. Thanks for your great service here at Largo Hospital for so many years. We won't say how many today. Hey, we want to see more videos and photos of 12 and up getting the shot. You can upload your images using Facebook Messenger here at the Kansas Health System or send to us at medicalnewsnetwork@kmc.edu. And remember, as you go back out in the public, that the rules of infection control still keep you safe wherever you go. Wear your mask if you have any doubts. Even if you've been vaccinated, wear a mask if you're concerned. Keep your distance if you're concerned. Cough into your elbow. Check your temperature if you go outside and you think you're sick at all. Don't go out and do that. Don't spread that disease. Help keep each of us safe. Help keep yourself safe. Help keep the world safe. And make sure you get vaccinated. We'll see you soon.